So if you survived a massive heart attack back in like the mid-1950s, your doctors might have prescribed you this very specific cutting-edge medication.
Right.
And it was highly effective, but it was also literal rat poison.
Which is just wild to think about.
It is, and that is exactly what happened to United States President Dwight D. Eisenhower in 1955.
Yeah.
And the crazy part, it actually saved his life. So welcome to today's deep dive. Today we are exploring the terrifying high-wire act of anticoagulants. We're looking at heparin, warfarin, and, the modern DOACs, and how healthcare professionals walk this incredibly narrow line between preventing deadly clots and, well, causing dangerous bleeding.
It really is probably one of the most perilous tightropes in medicine. Because when we talk about anticoagulants, we aren't just looking at like a simple list of medications.
Right.
We're looking at this highly complex, highly reactive biological system inside you. And the tools we use to artificially manipulate that system, they've evolved drastically over the last century.
Especially with that massive explosion of new drugs around, 2010?
Exactly. So understanding the evolution of these therapies and why matching the right drug to the right patient is literally a matter of life and death is just fundamental.
Okay, let's unpack this right away. Because before we get to the rat poison, we have to debunk a massive, widespread myth about this entire class of drugs.
Oh, the blood thinner thing.
Yes. The colloquial phrase everyone uses is blood thinners. I mean, you hear it from patients, you hear it on TV shows, but it is entirely misleading.
Completely.
Anticoagulants do not actually thin your blood. They don't, change the viscosity of the fluid. We aren't taking a thick liquid and watering it down like you're adding paint thinner to a can of paint.
That is such a vital starting point. I mean, the fluid dynamics, the actual physical thickness of the blood in your veins, it remains exactly the same whether you're on an anticoagulant or not.
So instead of thinking about plumbing or like paint thinner, I want you to think of your body's coagulation system like a highly coordinated factory assembly line.
I like that analogy.
Yeah, so when you get injured, the factory alarm bells ring. The assembly line kicks into gear, sending proteins down the belt to build a solid, temporary structure to patch the leak, which is a blood clot.
Right.
Anticoagulants don't flood the factory floor with water to thin everything out. They just change the kinetics of that assembly line. They basically throw a wrench into the machinery.
Exactly.
So if you are taking an anticoagulant and you cut your finger slicing an onion, you aren't bleeding thinner blood. Your factory is just taking way, way longer to build a robust clot. You bleed longer, not thinner.
And that distinction dictates everything about how these drugs work clinically. To really grasp how we control this complex factory today, we should probably look back at how we accidentally discovered the brakes for this assembly line in the first place.
Which brings us to the accidental discoveries. So in 1916, there was this second-year medical student at Johns Hopkins named Jay McLean. He was working in the lab of a physiologist named William Henry Howell. And McLean's assigned job was to isolate procoagulant substances from dog liver and heart tissue.
So he was explicitly looking for compounds that caused blood to clot.
Exactly. But instead of finding a clotting agent, he isolated this fat-soluble compound that did the exact opposite. It prevented clotting entirely.
Which is just a phenomenal example of scientific serendipity. I mean, Howell eventually named this mysterious compound heparin, which comes from the Greek word heper, meaning liver.
Because that was the primary tissue they were extracting it from.
Right.
But, they couldn't just inject raw dog liver extract into humans. It took a long time to refine, didn't it?
He did, yeah. It wasn't until the 1930s that chemists, specifically Charles Best, who, was already famous for his role in discovering insulin.
Oh, wow.
Yeah, he managed to purify heparin to a standard where it could actually be used safely in clinical practice.
So heparin comes from a pretty straightforward, if lucky, laboratory stumble. But warfarin's origin story is like something out of a Gothic agricultural mystery.
It really is.
Here's where it gets really interesting. In the 1920s in Alberta, Canada, a veterinary pathologist named Frank Schofield noticed a terrifying trend.
All right, the cattle.
Yes, cattle were bleeding to death from incredibly minor injuries. We're talking about like a basic nosebleed or a tiny scratch from dehorning, and the animal would simply exsanguinate.
So awful.
Yeah, and Schofield traced the cause back to their feed. They were all eating spoiled, moldy, sweet clover hay. He named it sweet clover disease, but the actual biochemical mechanism remained a total mystery.
Until the crisis hit a tipping point in the American Midwest.
So in 1933, a Wisconsin farmer named Ed Carlson was losing his herd to this exact same mysterious bleeding.
Okay.
And he was just desperate for answers, so he loads up his truck and drives through a blinding winter blizzard to the University of Wisconsin.
Wow.
He walks straight into the agricultural chemistry lab of a researcher named Carl Paul Link. And Carlson just dumps his evidence right there on the desk.
Which was what?
A dead cow, a milk can full of unclotted cow blood, and a sack of that spoiled sweet clover hay.
Just a visceral, unforgettable delivery. Literally. So Link's lab spent years tearing that moldy hay apart biochemically. And finally, around 1940, they isolated the culprit. It was a compound called decumarol.
Okay, so what did the decumarol actually do?
They discovered that this specific moldy compound was actively blocking the animal's liver from recycling vitamin K.
Oh, I see.
And without vitamin K, the liver's factory assembly line simply cannot manufacture the clotting factors it needs.
So Link's team starts synthesizing all these different variations of the compound, and variation number 2 on their list becomes Warfarin.
Right.
Named for the Wisconsin Alumni Research Foundation that funded the research, combined with the Arin from coumarin. But when they brought it to market in 1948, it wasn't heart medication.
No, not at all. It was rat poison.
Because it was incredibly effective at its job. Rodents would eat it, show absolutely no symptoms for a few days, and then quietly bleed out internally.
Yeah, and the lead to human medicine happened under incredibly dark circumstances. Because in 1951, a U.S. military inductee attempted suicide by swallowing a massive, lethal dose of this warfarin rat poison.
Oh.
He was rushed to the hospital, but instead of dying, the doctors managed to save him by administering huge concentrated doses of vitamin K.
It proved the rat poison was a reversible pharmaceutical.
Precisely. That single medical intervention demonstrated that the drug's effect in the human body was dose-dependent, and that it could be completely counteracted if things went wrong.
Which paved the way for FDA approval, and eventually President Eisenhower taking it for his heart attack in 1955.
Yep.
So we have dog liver extract and rat poison, but how did they actually stop the factory assembly line from clotting without just, making patients bleed out completely?
To answer that, we need to look at the differences between how these drugs act on that assembly line. The coagulation cascade involves several inactive proteins, which we call factors floating in your blood. When an injury occurs, they activate in a very specific cascading sequence. Now, different drugs target very different workers in this factory. Let's start with the fast-acting one, heparin.
You mean unfractionated heparin, right?
Yes. Unfractionated heparin doesn't actually attack the clotting factors directly. It works by finding a naturally occurring security guard in your blood called antithrombin III.
Antithrombin III, got it.
Heparin binds to the security guard and supercharges it, accelerating its ability to neutralize two specific workers on the assembly line thrombin, which is known as factor II cria, and factor ZA.
Oh, wow.
And heparin accelerates this neutralizing process by 1,000-fold.
Wait, I'm confused about the timeline here. If it's supercharging a process that's already in the blood, how quickly does this happen?
It is essentially instantaneous. Because heparin is administered intravenously or via a shot under the skin subcutaneously, the onset is immediate.
Okay, so it's super fast.
Exactly. We use it when a patient needs their assembly line paused right this second. Like if someone hits the emergency room with a massive new pulmonary embolism, a clot in their lungs, or if they're going onto a cardiopulmonary bypass machine for open heart surgery, we use heparin.
But there's a catch, right?
A big one.
Yeah.
Monitoring it is an absolute nightmare.
Because heparin molecules are, bulky and unpredictable. They bind to plasma proteins and cell walls in totally random ways depending on the individual patient.
Yeah, that unpredictable binding means a dose that is perfectly safe for one patient might cause catastrophic bleeding in another of the exact same weight.
Which is terrifying.
It is. So nurses have to constantly draw blood to check a lab value called the aPTT, the activated partial thromboplastin time. They're constantly tweaking the IV drip rate up and down hour by hour, trying to keep that lab value perfectly balanced between 1.5 and 2.5 times the patient's normal baseline.
It sounds like an exhausting minute-by-minute balancing act, which makes sense why science went looking for an upgrade. And that upgrade was low molecular weight heparin, or LMWH. Drugs like enoxaparin, which most people know as Levinox. But why does changing the weight of the molecule suddenly make it easier to deal with?
Well, they literally took the massive, clunky heparin molecule and chemically chopped it into smaller, uniform fragments.
Oh, I see.
Because these fragments are smaller and cleaner, they don't get caught up binding randomly to other proteins in the blood. They act with precision. selectively targeting just factor Z.
So the clinical payoff must be massive.
Huge. You can give it as a simple shot under the skin based purely on the patient's body weight. Because it is so predictable, for the vast majority of patients, you don't need to chase those exhausting aPTT lab values at all.
Okay, so heparin and Lovenox are the fast-acting, immediate breaks approach. Let's contrast that with warfarin, the slow approach. You mentioned earlier that warfarin works in the liver.
It does. It targets an enzyme called VK or RC1. Think of this enzyme as the loading dock manager for your factory. This manager's only job is to recycle vitamin K and bring it into the factory to build specific parts. Warfarin basically fires that loading dock manager.
Right.
So suddenly, the liver cannot make functional versions of 4 very specific factors. Factors 2, 7, NIX, and X.
So what does this all mean for the patient taking the pill right now? Like, if I swallow a warfarin tablet on a Monday morning, my blood doesn't instantly stop clotting, does it?
No, not at all.
Because warfarin doesn't hunt down and destroy the clotting factors that are already swimming around in my bloodstream. It only stops new ones from being built.
Exactly. And those existing factors have varying lifespans. Prothrombin, which is factor 2, has a massive 60-hour half-life.
Meaning it takes 60 hours for just half of it to naturally clear out of the system.
Yes.
So if I take the pill on Monday, it takes 3 to 5 days for the old factory workers to retire and for the warfarin to actually take full effect.
Which is exactly why we monitor it differently. Instead of the aPTT, warfarin is monitored by the PT, the prothrombin time. This is standardized globally as the INR, the International Normalized Ratio.
Okay, so what's the target there?
For a typical patient with, say, atrial fibrillation, we want their INR between 2.0 and 3.0. If they have a mechanical mitral valve in their heart, which is a highly reactive piece of metal prone to clotting, we push the target higher, usually 2.5 to 3.5.
And if someone's INR shoots up to like 8.0 and they start bleeding dangerously, the reversal agents are very different from heparin, right?
Totally different.
Because for heparin, you use a drug called protamine sulfate. But for warfarin, you have to replace what's missing. You give them vitamin K to restart the loading dock.
Right.
Or if they are actively hemorrhaging, you give them fresh frozen plasma or a prothrombin complex concentrate like Kcentra, which physically replaces the missing factory workers immediately.
What's fascinating here is that mismatching the speed in the labs of these two drugs ignores the entire logic of clinical therapy. You cannot monitor warfarin with an aPTT, and you cannot monitor heparin with an INR.
Because they're attacking the factory in completely different ways.
Exactly. And that 3 to 5 day delay for warfarin, it's not just a minor inconvenience. It actually creates a deadly window that leads to some of the most counterintuitive phenomena in all of medicine.
This is where the tightrope gets really wobbly. Let's talk about the paradoxes.
Yeah, so when you start a patient on warfarin, you are suppressing those 4 pro-clotting factors we mentioned, but you are also suppressing some naturally occurring anti-clotting proteins, specifically protein C and protein S.
Because they rely on that same vitamin K loading dock.
You got it.
Ah, I see where this is going. Protein C is a natural break for the assembly line, and its half-life is incredibly short, only about 8 hours.
Right.
So the natural break disappears in 8 hours, but the pro-clotting factor 2 takes 60 hours to disappear.
Which creates a terrifying biochemical traffic jam. For the first 24 to 72 hours on warfarin, your body's natural anti-clotting defense completely vanishes, while the pro-clotting workers are still actively building clots.
That sounds really dangerous.
It is. For a few days, the patient is paradoxically hypercoagulable. They're far more likely to form a blood clot than if they hadn't taken the medication at all.
Which can lead to a horrifying condition called warfarin-induced skin necrosis, right?
Unfortunately, yes.
It happens in about 1 in 10,000 cases. Because the patient's blood is temporarily so prone to clotting, thousands of microscopic blood clots form and clog up the tiny vessels in their skin. It causes these intensely painful purplish lesions, often on the thighs, breasts, or buttocks, leading to severe tissue death.
This physiological paradox is the entire reason the concept of bridging exists. You can never just hand a new patient a warfarin pill and send them home. You have to bridge them.
So how does that work?
You give them the slow-acting warfarin, but you also give them fast-acting heparin or Lovenox injections at the exact same time. The fast-acting heparin protects them through that dangerous 3-day startup window until the old clotting factors finally die off.
Oh, and then the warfarin fully takes over, and the INR hits that therapeutic 2.0 to 3.0 range.
Exactly.
But bridging relies on heparin, and heparin has its own terrifying paradox, doesn't it? Something called HIT heparin-induced thrombocytopenia.
It is arguably the ultimate medical betrayal. I mean, the anticoagulant itself causes massive catastrophic clots.
Wait, really?
Yeah.
Oh.
In about 1 to 5% of patients on unfractionated heparin, their immune system suddenly misidentifies the drug. When heparin binds to a specific protein in the blood called platelet factor 4, the immune system views that complex as a foreign invader.
Okay.
And so the body creates aggressive antibodies against it.
So it's like calling the fire department and they show up with flamethrowers. The immune system's security guards start attacking the factor itself.
That's a great way to visualize it. These antibodies violently activate the patient's platelets. The overall number of free platelets in the blood drops dangerously low. That's the thrombocytopenia part.
Right.
But the platelets that remain are aggressively clumping together, forming massive clots. Patients end up with catastrophic arterial and venous blockages. We're talking debilitating strokes, loss of blood flow to their arms or legs, which we call limb ischemia, and massive pulmonary embolisms.
So if a nurse or doctor is looking at daily lab results and they see a patient's platelet count suddenly drop by like 50% a week after starting a heparin drip, what is the protocol?
The required nursing and medical action is absolute. You stop all heparin immediately. You even throw away the tiny heparin flush syringes used just to keep IV lines clear. You must switch the patient to a completely different class of anticoagulants like argatroban or fondaparinux.
Okay, so you switch them, but you don't use warfarin.
Critically, you never switch them acutely to warfarin because, as we just discussed, warfarin causes that early protein C drop. If you give warfarin to a patient actively suffering from HIT, you're throwing gasoline on a hypercoagulable fire.
It is just wild how carefully this assembly line has to be orchestrated. Every single intervention has a domino effect.
It really does.
Which really explains why the medical world was so desperate for an easier way. Chasing aPTT labs, checking INRs, bridging patients with multiple drugs, constantly worrying about skin necrosis and HIT, it's exhausting for providers and patients.
Oh, absolutely.
So we inevitably got the DOAC revolution.
Right. The direct oral anticoagulants, which started emerging in the 2010s, drugs like dabigatran, rivaroxaban, apixaban.
And they were kind of pitched as a miracle, right?
Pretty much. The pharmaceutical industry marketed them as the ultimate holy grail, freedom from the constant needle sticks for blood draws, freedom from strict diets. You just take a pill and you're protected. And today, we even have specific reversal agents for them, like idarucizumab and dexanet alpha if bleeding occurs.
But we have to look at the famous DOAC failure, the 2013 REALIGN trial. Researchers wanted to see if they could use dabigatran, this shiny new DOAC, on patients who had mechanical heart valves.
And the trial was an absolute disaster.
Really?
Yeah, they had to stop it early. The data was undeniable. The patients on the new DOSC had significantly more strokes, way more clots forming directly on their mechanical valves, and far more major bleeding events compared to the patients on old-school warfarin.
Wait. The entire point of medical advancement is that the newer, more targeted drug is safer and better? Are you saying we gave them the cutting-edge DOAC and they actually got worse?
That's exactly what happened.
How does that make any sense? I mean, if a DOAC and warfarin both stop the blood from clotting, why does a piece of metal in the heart care which drug is doing the job?
It all comes down to how they shut down the factory. DOACs are highly targeted. They act like a sniper, taking out one specific worker on the assembly line, like factors AST or thrombin.
Okay, a sniper.
But warfarin is a sledgehammer. It blunts the production of multiple clotting factors simultaneously. A mechanical heart valve is a highly reactive, incredibly clot-provoking piece of foreign material inside the body. A sniper isn't enough to stop the cascade when the stimulus is that aggressive.
Ah, so you need the sledgehammer.
You do. It's a massive teaching point. Newer isn't automatically safer. DOAs are strictly contraindicated for mechanical heart valves.
That perfectly illustrates why memorizing drug names isn't enough. You really have to understand the underlying mechanisms.
Absolutely.
And speaking of understanding mechanisms, there are a lot of persistent myths surrounding anticoagulants that we should clear up. Let's start with aspirin. A lot of people assume aspirin is a blood thinner, just like warfarin, and does the exact same thing.
A very common but dangerous conflation. Aspirin is an antiplatelet. It irreversibly inhibits an enzyme called COX-1.
So going back to our factory analogy.
In the context of our factory, aspirin stops the raw materials, the platelets, from holding hands and clumping together in the first place. Anticoagulants, as we've discussed, stop the chemical factors that pour the concrete to cement that clump together.
So they're working on totally different parts of the process.
Right. Clinically, aspirin works mostly on high-pressure arterial clots, which cause heart attacks. Anticoagulants dominate the slower venous, side-deep vein thromboses, pulmonary embolisms, and atrial fibrillation. Treating one like the other leads to major clinical failures.
Okay, what about the spinach myth? The idea that if you are prescribed warfarin, you are never allowed to eat a green leafy vegetable again because they're packed with vitamin K.
The actual medical guideline is consistency, not total avoidance.
So you can eat it?
Yeah, if you love spinach, eat the exact same amount of spinach every single week. Your doctor will simply adjust your baseline warfarin dose to match your steady spinach intake.
That makes sense.
The real danger is eating 0 vitamin K for a month, letting your body acclimate to that, and then suddenly eating 3 massive kale salads over a weekend. That sudden flood of vitamin K overwhelms the loading dock and sends your INR swinging wildly out of control.
And for patients who switch to the DOACs, it's often said they require absolutely zero monitoring. Just prescribe it and forget it.
Well, they don't need INR checks, which is a relief,
Yeah.
but they absolutely do require renal function monitoring.
Because of the kidneys.
Right. Drugs like dabigatran are cleared from the body heavily by the kidneys. If an elderly patient's kidney function starts to silently decline over a few years, the DOAC isn't filtered out. It builds up in their system, leading to dangerous, spontaneous bleeding, even though their daily dose never changed.
Which ties perfectly into a massive misconception about labs in general. You know, this idea that if a patient's INR is perfectly within the normal target range, they are completely safe from bleeding to death.
That is an incredibly dangerous assumption. A perfectly therapeutic INR just tells you the chemical speed of the clotting cascade in the blood. It doesn't mean the patient's physical anatomy is safe.
What do you mean?
If they have a structural lesion, like a deeply bleeding peptic ulcer in their stomach, they can easily hemorrhage to death even with a perfect INR. The drug isn't causing the bleed, it's just preventing the body from stopping it.
Wow. So we've tracked the history from lucky dog liver extracts to the isolation of literal rat poison in a blizzard. We've mapped the mechanic, the fast-acting heparin wrench versus the slow-acting warfarin supply chain disruption, and the sniper-like modern DOACs.
We covered a lot.
We did. But why does walking this incredibly complex tightrope matter so much to the broader medical system today?
Well, if we connect this to the bigger picture, the stakes couldn't be higher. Take atrial fibrillation, an irregular heartbeat. It affects millions of adults worldwide. Because the blood pools in the heart, it is prone to clotting. If left untreated, AFib multiplies your risk of a devastating stroke by 5. Meanwhile, deep vein thrombosis and pulmonary embolisms are among the leading preventable causes of death in hospitalized patients.
That is why almost every single patient admitted to a hospital today gets a risk assessment and usually a preventative weight-based shot of Lovenox.
Exactly. And because that therapeutic window between fatal clotting and fatal bleeding is so incredibly narrow, anticoagulants are consistently ranked among the top drug classes responsible for serious adverse events and hospital readmissions.
So every single time a nurse double-checks a heparin drip rate against an aPTT lab or questions a physician's warfarin dose because the INR is creeping up to 4.8, they are literally holding a life in their hands.
They absolutely are. And this science is highly active. I mean, during the COVID-19 pandemic, the medical community realized the virus was triggering massive atypical clotting complications.
Right, that was a huge issue.
Suddenly, manipulating this assembly line became the absolute center of clinical trials and intense medical debate globally in 2020 and 2021. We are constantly searching for better ways to manage this biological system.
Which brings me to a final thought I want to leave you with. We spend so much time and billions of dollars fighting the coagulation cascade in medicine, but we have to remember that clotting is a profound evolutionary safety net.
It really is.
The exact same biological assembly line that saves us from bleeding to death when we get a tiny paper cut is the one that can kill us through a stroke. Right now, drugs like heparin and warfarin are brilliant life-saving tools, but they are incredibly blunt instruments.
Very blunt.
They don't actually cure the underlying disease. In medicine, we talk about Virchow's triad, the actual root causes of a clot. Those causes are stagnant blood flow, physical injury to the blood vessel wall, or a systemic hypercoagulable state in the body, like cancer or an infection. Anticoagulants don't fix any of those root causes. All these drugs do is artificially hold the assembly line workers apart so they can't finish the job. So the question is, as medical science advances far beyond the DOACs, will we eventually find a way to target the true root cause of the clot?
That's the million-dollar question.
Will we ever learn to actually fix the conditions on the factory floor rather than just disabling the human body's natural life-saving safety net? It's something to think about the next time you see a tiny scratch stop bleeding all on its own. Thanks for joining us on this deep dive. We'll catch you next time.